Now, does anyone know if we've got lots of people hanging around outside that haven't been looking at their watches and don't know that it's time to come in?
You have to look at your label and sit over there.
Ah, sorry, Alex.
That's
It's
all right.
because Isabel has stolen my seat.
No,
Yeah, but
yes.
Yeah.
and we're taking you in the order that we go in the program. Is that right? Okay. Good afternoon, everyone, for this final session of today. And what we're going to do is to have a hopefully very interactive discussion, which will look at the global dimension of migrants' health in context of economic restrictions. What is the way forward? And we have a stellar panel lined up. But before I introduce them, can I say that we're working on a way of getting a Twitter wall up. And because we want to make it as interactive as possible, can you post tweets using the conference hashtag? And I will be reading them here. So I will give priority to those who want to ask questions via Twitter. And after that, if there's anybody, if there are none there, then we will go to you in person. So that's the way to get your input into this. And I think we're going to work from left. We're going to work from my left to my right. Is that right? That's the way we're going. Okay, and we have, as I say, a stellar cast here. Daniel Lopez Acuna, who will be known to, I think, everybody, was for many years at PAHO running their work on health systems, and now is at WHO in the headquarters in Geneva. Isabella Della Matta, you've already met in the earlier session, and is the well, basically, she runs public health in the European Commission. She has another title, but the reality of it is that Alex Kalachi, who has a long and distinguished career in many roles, London School of Hygiene a long time ago, but for many years in WHO, and is now the president of the International Longevity Centre, and has been in the last few years particularly identified with the work on age-friendly cities, working with the New York Academy of Medicine. And Barbara Reichs, who's at the Migrant Health Division at the IOM, and who previously worked at Amnesty International, the UN Population Fund, and so on. So what we will do is to have brief interventions by each of the panel, and then we will open it up to discussion. But while they're talking, get tweeting. Daniel.
Okay. I'll use here. Thank you very much, Martin. Good afternoon to all of you. I'm going to make reference to some global aspects of migrants' health, very much connected with the work of the World Health Organization. My colleague Santino Severoni in the opening talked about some of the regional developments and the regional perspective, but let me mention to you three things in particular. The fact that during the 61st World Health Assembly, the 194 member states of WHO passed a resolution on migrants' health that has a number of implications, and particularly a framework for the work on migrants' health as acknowledged by member states. The fact that we organized 4 years ago a global conference in Madrid with the collaboration of the Spanish government in cooperation between IOM, International Organization of Migration, and WHO, and some of the important conclusions of the UN high-level dialogue on migration and development that happened around the General Assembly of the UN in October 2013. And I'll just do the highlights, and the presentation can be accessible later if you want. Just let me start by saying, and this is a map that IOM has put together, I think it's very important that we reflect about the nature of migration in today's global world. It is not a purely south to north phenomenon. And it is north-north, south-south, south-north, north-south. And the complexity of this dynamic, I think, also calls for a much more elaborate set of actions if we want to tackle effectively issues that have to do with migrants' health. Just to say that in 2008, the World Health Assembly passed this resolution with some elements that are critical, calling for a much more migrant-sensitive set of health policies that emphasize equitable access to services of migrants regardless of their migrant condition. And also that highlight the need of capacity building of the health services providers and the health professionals to deal with the issue of migration and health, and to be able to advance more migrant-sensitive delivery of services. The resolution underscores as well the need of bilateral and multilateral cooperation and intersectoral action. This is not only a health matter, it's a health and other sectors, and also requires much more dialogue and cooperation between countries of origin, countries as destination, and countries of transit. 2010, a global consultation, academia, governments, civil society, migrant associations, etc., very much multi-stakeholder, to take stock of the actions in all regions of the world, not only in Europe, not only in the Americas, but all over, to try to reach consensus on some priority areas and strategies, and to initiate some elements of an operational framework to assist member states and stakeholders. The fundamental elements in that discussion and in the resolution and the documents that were backing the resolution in WHO was, let's go for, or let's transit from a traditional approach where the issues, the concerns are security, exclusion, to an approach, and this is certainly a paradigm shift, a more modern and multi-dimensional approach of inclusion, of reduction of inequities, of social protection in health. And let's apply a public health strategy, ensuring migrants' health rights, at the same time that we also tackle the issue of reducing excess mortality and morbidity, that we can impact on minimizing the negative impact of the migration process, and that we can contribute to avoid the disparities in health status and in health access. And the four basic areas, and I will not go into the details, it is in the report, it's in the web, you can consult it, that were discussed in Madrid, where we need to do a better job in monitoring migrants' health, in documenting the health of migrants, not only in terms of morbidity and mortality, also in terms of healthcare seeking behavior, in terms of access to health services. We need to do much more work in the policy legal frameworks, especially those that are connected with social protection in health of the migrant population, especially the undocumented migrants. We need to work more on developing the capacity of the health workforce and the ability of the systems to deliver migrant-sensitive health systems, and we need to enhance these partnerships. I will just go to conclude, not so fast, on the issues that were discussed recently in the high-level dialogue on migration and development. I think what is important, that this happens only every 7 years in the UN, but there was a clear acknowledgement and recognition by member states that migration is in the center of the debate internationally and needs to be much more in the center of the work of the UN. That needs to be much more present in the debate of the post-2015 development agenda, and that there is a need of strengthening partnership for addressing the migration challenges. Bottom line, what is ahead of us? Where is it that we have to transit based on some of these intergovernmental recommendations? Well, this global agenda on migrants' health implies that addressing the health of migrants protects global public health and facilitates integration and contributes to social and economic development. We need to enhance the evidence base for documenting this, and this I mentioned to particularly research community. The need of including migration and health in the post-2015 agenda. The fact that this is consistent with the ILO resolution on social protection floor, is consistent with the Assembly resolution of the World Health Organization, things where governments have said we need to go in this direction. So now they have to walk their talk. It's also important to implement these migrant-sensitive health policies, incorporating the public health approach, equitable access to health services, and we have talked regardless of their status and stigmatization. The coherence of policies between different sectors, the development of and strengthening of bilateral and multilateral social protection agreements between source and destination countries that include healthcare benefits and portabilities of these healthcare benefits, and that we anchor much more this debate of the UN and try to promote in so many countries that are working in this direction in a collaborative approach of the UN institutions in the UNDAP or one programs as migration and development and migration and health as one of the central axes for the interagency work in support to member states. I'm going to stop there.
Okay. Thank you very much indeed. And we will now move on directly to the European Commission in the form of Isabel Della Mata, who will tell us about your response, your organization's response in the face of austerity and the crisis and all the problems that we face.
Yeah, okay. So, we have two kinds of responses for the two different issues of migrants and ethnic minorities. For ethnic minorities, it's much more easier because we have defined, we have focused on Roma, even if Roma is quite large, but like that we have the discussion or the dialogue more center. For the migrants, we are still trying to decide what we mean by migrants, because I mean, I am a migrant, irregular, undocumented in Belgium, but it's sure that nobody is referring about me. And in the same opposite way, for the informal meeting of Minister of Health that will be held in 2 weeks in Athens, they seem to be focusing just in asylum seekers from Syria and Northern Africa, and this is also very restricted. And we want to say something more, but we have the migrants of different kinds, regular, irregular, asylum seekers from inside the EU, outside the EU, third countries, and we are discovering that we have also problems with migrants coming from other countries of the European Union, that just like that, we discovered that after 3 months they can be expelled of any country of the European Union. So the free movement of persons, that was one of our pillars, is not true anymore since the residence directive that was approved. I don't remember when, some years ago. So the population is quite large, and first, it's not the health directorate who is dealing with that, but it's the DG Home, Internal Affairs, the Ministry of Interior of the European Union, or the Ministry of Justice, DG Justice, when we are talking about inequalities and discrimination and things like that. So we are always behind the rest. And, but we don't have a behavior that is different to any member state. I mean, we try to say that health and healthcare is for everybody, and the responsible ministries of economy and interior are telling us, yes, but who is going to pay? Yes, but not, because there is no regulation, or there is a regulation that is saying a different thing. So we are in that area. In the meantime, we have discovered that we don't have much money. This is not a surprise. For the health program, we are trying to do something with the few money that we have, that is to work with the IOM, to work with WHO, to work with the School of Granada in the training package, so in different things. But we had some good news, and is that we have discovered that the European social funds, now they are obliged to spend 20% in promoting social inclusion and combating poverty. And one of the important population that is socially excluded and poor are the migrants. In the we know what we can tell when we talk about migrants, so migrants in difficulties. And at the same time, we have also discovered that the European Regional Development and Investment Fund, that before couldn't be used for health, or when began to be used for health was just to build hospitals, to build health centers, or whatever, now can be used for everything on health, And the same for the Roma. So that is obliging us to work more with the rest of the general directorates of the Commission, and at the same time, these are obliging them to work with us. Because for the Roma strategy, we have put 4 legs, and even if they forgot very often that the 4th one is health, we are there to remind them that it's not just an employment of education or housing, but that health is an important thing. So I mean, it's not an excuse that the main responsibility for the health system, the financing, the organization, the delivery is for member states, but we are trying. We have put these programs under inequalities in health, and trying to expand inequalities not just for the European Union citizens, but for everybody. And remembering all the member states that even if they are free, there are something general that are called the universal rights and etc. that at least you have to provide healthcare, emergency healthcare, healthcare for the children, and healthcare for the pregnant women in before, during, and after the delivery. So very short that.
Okay. Thank you very much indeed. Now we will go on in this vein with some brief presentation, continue the presentations before we get into the debate. Can I just at this stage thank Anna Isaacs for the first question that has been tweeted. We're saving them up here, but I would encourage more of you to add in your tweets so that we have more for discussion. Barbara, please.
I do better standing up, so it's gonna just... Good afternoon, everyone. It's a privilege for me to be part of this panel. On behalf of my boss, Dr. Mosca, I work for the International Organization for Migration at the Migration Health Division. My presentation will touch upon two brief issues. One, trying to highlight some of the main challenges at global and national level, and then some recommendations to move the migration health agenda forward, both at country and global level. First of all, challenges at global level. Maybe building on some of the things that Daniel just mentioned, that migrants' health is generally not integrated in the global health debate. We still see lack of attention to migrant health in general health discussion at WHO, in specialized thematic conferences and declarations like social determinants of health or NCDs. The only exception is perhaps HIV and TB strategies, where we see now more inclusion of migration. I believe next to WHO there will be a new strategy on TB in the post-2015 where migrants are explicitly recognized, including the WHO resolution. Generally what we find is a lack of awareness and enforcement of international commitments on migrant health. There's a preoccupation with the health of its own nationals and lack of interest in migrant health. Often is related to cost as well. Then the other element is of the migration and health dichotomy, if you will, is that migration health is not integrated in the migration debates. Some of the people have already addressed that in earlier debates, but although Daniel's right that there's more of a migrant-centered approach now in the high-level dialogue on migration and development, we still see WHO and IOM have to really push hard for a focus on migrants' health in migration and development discussions, and to more and less success. This is because of these dialogues are led by the migration sector. So generally what we see in these forums, you have the ministries of immigration, maybe labor, foreign affairs, general lack of interest in migrants' health, general preoccupation with costs and misperception. In 2010 we had the Global Forum Migration Development, where we had the only really health recommendation was the assess cost-effective healthcare models for various types of migration scenarios. So you can kind of see where the thinking is around the migration sector. Maybe I should also mention I work for a migration agency, so I on a daily basis I deal with integrating health in migration. So I even have to convince we have an issue around interest and understanding of really what the migration health issues are within IOM. Some of the other issues at global level, Daniel already mentioned the post-2015 development framework. Some of you might think this is really boring, not very interesting. Why should we worry about it? You know, like I think we've seen a real, kind of convergence around the importance of MDGs at the moment, and they are important because more and more countries want to focus on specific health goals and other type of development goals, and it's really important because funding is going their way, attention is going their way, so we need to make sure that some of the key points that we're trying to stress are integrated. There the problem is that most of these discussions are ministries of development, maybe foreign affairs, who are attending these sessions. So it's not even sometimes the technical ministries of health or social affairs or even immigration education are sitting around the table. It's generally kind of diplomats at New York or Geneva level, mainly New York in this case. Now, why is it important also? There's a couple of these discussions been going on for a while, and the new development framework will be, as far as I know, adopted in 2015. What is different between that one and the current one is that it will be universally applied. So it's not just for development countries, it's truly universal. So for Norway as much as for Namibia. So it's really, it is something, because we see development now much more as a holistic thing around health and well-being and general human development rather than just on economic indicators. So far in the discussions, where the discussions now in the post-2015 is that we have about 19 focus areas. I'm pretty sure that will be narrowed down at some point. Only one is on health and population dynamics. And the current discussion where we have now is still very much focused on universal health care and diseases. Very little focus on social determinants of health, issues around social protection. So this is really important for the migration health agenda, is that we try to include that in our advocacy, and that's what we're trying to do. Then at national level, I don't have to spell it out for you, but obviously we're still battling with myths and misperceptions. Generally, I think one of the main areas where we're really struggling is in the lack of policy coherence, lack of multi-sectoral dialogue and collaboration among the different sectors. And I would say maybe 3 key sectors, immigration, health, and labor, is where it's most relevant for migrants to come together. And I would say both government and non-governmental actors within these sectors are not actively collaborating, and policies still happen to be incoherent. A good example is, for instance, the health-related travel and entry restrictions, where we see an immigration policy having direct effect on whether excluding on health conditions has a direct effect on the migration decision. There's quite a big discussion in Europe, not as much, but in countries, for instance, in the Gulf and the Middle East, it's still very much an issue. Then obviously, as we know, some of the inconsistencies between restrictive immigration policies and maybe progressive health policies, they just don't talk to each other. Some of the presentation this morning looked at these silos. This is exactly the silos that we're talking about as well. Generally, we see that there's very fantastic recommendations at global and European level, but generally not a lot of follow-up. For instance, we still don't have as Daniel said, a fantastic resolution on migrant health, but there's no regular reporting on that resolution. And generally, it's already been said, but there's a lot of discussion around migrant health, keeps talking about access to healthcare and not as much as social determinants of health, whereas the social determinants of health are much more obviously impacting on the health status of migrants. Now, moving to some of the key recommendations. Again, I think it's nice that some of the stuff that I've tried to present here has been said before, so I think some of the discussion I just came out of a workshop was exactly on this issue. We need to have and produce and communicate evidence that policies makers are asking for, and that is also policymakers outside the health sector, like immigration and labor and health, especially related to cost effectiveness of providing healthcare to migrants and good practices of providing cost-effective health programs and health services. Only about 2 weeks ago, I met with some Ministry of Immigration. I'm not sure what exactly the name, Interior of Greece, and this is really what they're interested in. We're struggling. We have very little money. We want to know what is the basic packages, what does it cost, and especially for undocumented migrants. And you try to explain it's not just about the cost of treating; it's about the cost of not treating. But they want some answers, and I think we need to start to provide some of these answers in a right way. And then, as I mentioned before, I think it's really key to strengthen intersectoral and sectoral collaboration on migrant health. For instance, we really need to start looking at integrating or establishing focal points in ministries of health that then can coordinate with other line ministries to come up with a more coherent response to migration and health. We hardly see this happening still. In that way, is also there will be a more, let's say, non-health focus on social determinants of health, looking at health in all policies. I think that's a really key issue. Also, I think we've said it before, but I think within the, I think it was Isabel who said it maybe a while ago in another conference, we keep talking to the converted. You know, the health sector is already converted. We know, even if you're most let's say conservative health person, or health government, you can still see that that there's a good public health argument and health economics argument to provide healthcare. But I really believe that we need to strengthen the dialogue and the mechanisms for intersectoral dialogue between the health sector and other sectors. For instance, it might be an idea, you know, given what I've just said, to facilitate dialogue between academic public health community, government health partners, and ministries of development or foreign affairs around the post-2015 input. How many of you have sat with your ministries of health and say, what is going to be our input for the post-2015? You know, this is the kind of, I think, partnerships we need to try to come up with. Another, I think, important part about intersectoral approach is not just about sort of at national level, at senior level, but it's also bottom up. We need to start looking at what's happening on the ground. For instance, IOM and partners are working quite strongly on the issue of training of immigration and border officials on key aspects of health, and generally with very great success. Like people like immigration officials, even lower level, but they're directly dealing with the migrants on the ground. They want to know what's going on. They learn about migrants' right to health, how to refer to health services, their own health, and how to protect their own health. So really important to...
We'll come back to all of it if we just...
Sure. Okay. Similar way, look at, for instance, health professionals. Now, the last point I wanted to make was around strengthening intersectoral dialogue and mechanisms. It's not just at national and but also at subnational level. And that is really, I think, what we're trying to end up with is really a whole of society, whole of government approach to migrant health, where you're not only working between sort of the national level, if this is your national federal level, your provincial and local level, but that there is collaboration between the national level within one sector and the local level. Often at the local level, the health authorities have much to do with health at local level, and they don't know what's going on. The national people don't know what's going on, so they need to move to the lower level. Similar between the sectors, and really important to move between the sectors, between the levels of government, and to work with local officials. Just then, very shortly, on global level, some of the key issues. I think I would really summarize it in 2 points. One is the monitoring at global level and at regional level through standardized framework. We have a very good new instrument that is starting to, I think, be implemented this year. It's called the health strand within the MIPACs. So this is the migration index, the migration integration index in Europe, and other countries outside of Europe are using this instrument as well. Very good that health is now seen as a key element of migrant integration, and it's very nicely broken down into different indicators. As a global partnership of organizations, we really should try to come up with one global monitoring framework on the WHO resolution. Then lastly, I said it already before, but I think we really have to look at strategic partnerships across the different disciplines, across the different sectors, and I'm not sure we're doing that enough. For instance, as I said, between NGOs, IOs, academic and government partnership to advocate for inclusion. We also, as was said before this morning, maybe trying to unite some of the public health academics with human rights and development practitioners, and avoid the divisions between migrant ethnic minorities and health equity, as we discussed this morning. And then lastly, maybe the point that Raj Bhopal made yesterday, that maybe we also need some high-profile advocates or ambassadors to talk about migrants' rights. Maybe we need to look at a high-level, high-profile economists, or maybe a World Bank or ex-World Bank official that can talk about the numbers and the public health arguments, rather than people from the health sector that might be more convincing. So I think those are some of the partnerships we could look at. Thank you.
Thank you very much indeed. Thank you very much indeed. And we'll now move rapidly on to Alex, and then keep the tweets coming in. We've got a couple of questions here, but we want some more.
Thank you very much, Martin, and I'm sorry I'm going to disappoint you. I'm going to speak a bit long. mostly because I have a very formidable task here. I have to bring to the horizon, to your radar, something that doesn't seem to be there at all. If you look at this compendium, with all the abstracts, I have found one single reference to older migrants. The impression is that migrants are forever productive and young. And I'm sorry, I'm going to disappoint you. Migrants also have the very bad habit of getting older, and the policies are not there. They are ignored, bypassed, and they are among the most vulnerable of all groups. The other thing that I want to say is the person who had the only one mention to old age is Tinek Fokema. Is she or he here? Well, the title of this only paper that addresses aging is Feeling Lonely in a Foreign Country, Coping Mechanisms of Older Migrants in Italy. Feeling lonely. It's a bit like, you are there.
Okay, so we have two papers out of the
Two
entire
papers.
conference on older
Wonderful.
migrants.
So I'm not feeling so lonely. That's very good. Well, I was going to say that I feel lonely because again and again I have been to many different conferences on migration, and it is the same. The community that does research on aging ignores migration. The community that does research on migration ignores aging. And yet we are faced with a revolution that I call the longevity revolution. Just look at this. Worldwide, in this century that we are going through, starting in 1950, the total population is going to increase by less than 4 times. The population aged 60 plus, 10 times. And the population that is 80 plus with special needs, including older migrants, 26 times. Worldwide, in the same century, we are going to see the total number of 80 plus going from 14 million to virtually 380 million. Lot of people. And we have to address these needs, not only of this aging society. If you look at my country, in Brazil, I was born in 1945. Can do the counts. I'm 68. 43 years was the life expectancy that I had expected to have when I was born. Today is 75. It's not 32 years of old age. It's 32 years of life. And the implications are retroactive throughout the life course. It will impact all of you. And we have to face this longevity revolution. If you look at again in Brazil, life expectancy at birth was in 1945, 43 years, today 75. Population, 50 million, today 200 million. And urbanization, we had 30% of the total population living in urban areas. Today is 88. So it's 88 of 200 million. It's a very different country. And built into this urbanization, we have migrants, internal migrants, that are now aging, sometimes in a big country like Brazil, 3,000 to 4,000 kilometers away from the home place. We also have to address their specific needs. We had 23 million people in 2012 above the age of 60, 12%. By the year 2050, will be 64 million, much bigger than the total population of this country. Then we have migration. We know that we have about 250 million legal international migrants, and they're counting. We don't even know how many illegal. This boy, born in 1945, was not supposed to be here. I was not programmed to be here. Not only in terms of life expectancy, but also I was not even programmed to be born, because all my grandparents were migrants from different countries, from Greece, from Italy, from Portugal, and from Lebanon. My father was a migrant. He was born in Syria, then had to migrate to Turkey for religious reasons, and eventually ended up in Brazil. If it were not for the history of migration that is following up this century, I was not even supposed to be here, neither I was supposed to be born, let alone to have survived. And this is what is so important for us to bear in mind, that people like me are not going to be so exceptional, are going to be the rule in this aging world with far more migrants that are going to age. And you have seen, it is the result of your research, that aging is not, I'm afraid to say, in your radar, it's not in your books. I have mentioned this, that life expectancy is on the increase, and we're having many states in Brazil that have life expectancy as high as it would be in the old continent only a few years ago. But look at this, the effect of internal migration. Paraíba, which is right in the middle, one of the states with a high percentage today of older people in Brazilian terms, is a very poor state with the lowest life expectancy. Why is that? Because the young people move away and leave older people behind. So you have again the importance of aging in this respect, because so often the young migrants are here, but they leave their parents, grandparents behind, and this is also another consideration to make. What I'm trying to say is that we have three demographic major trends in the 21st century. We have aging, urbanization, and migration. And it's time to bring them together. Migration and aging, there are so many specific issues. For instance, the return home to a foreign country. You may have left behind, you may have moved away 40, 50 years ago, and then you make the mistake of going back, expecting that you will be back home. You are not. That country has completely changed, and so have you. So you end up aging in a foreign land that happens to be the land where you were born. You may expect entitlements that may not be there. Look at all the migrants that work in the United Emirates, in the rich Middle East. And they don't have the entitlements that they might expect, that their peers working side by side do. You have migrants here in Costa del Sol, the sun worshipping, from Sweden, from the Netherlands, from Britain, from Germany. You look at them, and I have visited the consulates of those countries here many years ago when I was working closely with this school. And these consulates in Malaga have become social welfare agencies because of these people with unmet needs. We have older people that are left behind, as I have mentioned. Also, older people that will join their families in older age, like my paternal grandparents that came to Brazil when they were already in their 60s. They never adapted themselves to that different culture. We have people that amass very little social capital, and this is what is the buffer for them to have a good age, and they don't have that. They may even be in good health, but without social protection. You have gender issues, women that have not even learned the local language and will end up widowed, estranged from their families, because also you have these generational clashes. Their children, let alone their grandchildren, with opportunities, education opportunities that they don't have, and the shock of values and principles that will put the young and the old within the same family far apart. What I'm talking is about vulnerability. Vulnerability, and I expressed this on this sentence, aging in a foreign land. I will skip many. I made a mistake, Martin. I thought that I was going to give a plenary keynote. And I will just mention here developing a culture of care. We had a seminar, a forum in Brazil at my International Longevity Center last October. And what we are talking about, this culture of care, is shifting the paradigm and placing the individual both as care receiver and caregiver at the center. And we talk about, in this real declaration, the result of this forum, on rights. The right to health, to learn, to work, to be protected, to have insurance, to participate, to have access to services. All these rights are missing there for many migrants, especially if you're migrant and old. We also need to talk about the right to stop, the right to rest, and the right to a basic income. The right to receive care. And this right to receive care is above all for those with diminished capacity to exercise this right, owing to physical or cognitive fragilities, but also socially induced, like migration. And at the root of all this is what you have both Daniel and Barbara addressed, is the need to fight exclusion. Extreme exclusion, and among the most vulnerable and excluded in all societies, including here in Europe, you will have migrants and older migrants. Be it symbolic, because the society is telling you all the time, we don't want you. You are of no use. You are no longer productive. You are not only foreigner, you are also old. Institutional, it is the health services telling us, you are a nuisance, a burden to us. It is the exclusion in socioeconomic terms, territorial. You don't need to be in a favela in Rio to be excluded territorially. You just go to the banlieues, to the suburbs of the big cities in Paris, in London, and you will see the migrants, especially the older ones, living there. The identity that yesterday I was a medical doctor, I was a car mechanic, I was a baker, today I'm nothing. I'm old and migrant. Exclusion because you haven't had time to accumulate and opportunities to accumulate social capital. And social political because you have very little opportunities to exercise your rights. Just to finish, within this longevity revolution, life has become much more a marathon than a 100-meter sprint. I'm saying this, of course, because in this pre-2016 Olympic Games, there is more so in Brazil than anywhere else, that we have to bring the attention to what I feel so strongly, because it's to do with my family, it's to do with my experience, having grandparents, a father, myself who lived abroad for 32 years, and my children who are migrants living in London. Thank you.
Thank you very much indeed. Wonder if I could kick off, because Daniel, you told us about the World Health Assembly resolution, and Barbara, you told us that nothing happens. It's not enforced. There's no enforcement. So I'm struck, and I don't know if other people are struck by this. We have heard throughout this conference of the most unspeakable actions against migrants. We heard the description yesterday from the Council of Europe of how some of the camps are essentially hellholes. And yet we have your representatives, the people that you vote for, your governments, who go to the Council of Ministers, who go to the World Health Assembly, and they sign up to all sorts of things, great words, but you're telling me that nothing happens.
I didn't say nothing. I think there's a lack of...
The microphone.
No, I think nothing is exaggeration, but I think there's a lot of gaps around still. Yeah.
So whose fault is it?
Member states.
Well,
it is member states, because you will have the organization, the international organization that you deserve. If you don't put teeth on these resolutions, if you don't ask for them to be monitored, it's not going to be monitored, it's going to be forgotten. So it is really you, the international community, that will have to go to the World Health Assembly or the equivalent IOM and say, yes, you need to come back here in 3 or 5 years and tell us what you have done.
Okay, Daniel, we need to get teeth into this. When I'm at the Regional Committee of Euro, other people are at the World Health Assembly. You know that we talked recently in the Lancet about the need to webcast it to get participation. The member states stand up and say things, and civil society produce documents which are tabled and are never actually spoken. What's going on here?
Lots of things are going on, and I think lots of responsibilities are there on the table. I agree with Alex. I mean, there is a responsibility of member states. But let me say 3 points. First, it's unfortunate in the governance system of multilateral organizations, WHO included, resolutions and commitments for member states are not binding. There is no enforcement. There is no, I mean, this is the nature of the beast. I'm not saying that it should happen or not. Of course it should happen. But this is a problem of accountability. And for me, this is a problem where we need greater citizens' accountability of the commitments by governments or by representatives. Second issue, it's very clear that we have a divide between the academic community or the research and academic community and the policy-making community. I was talking to several colleagues from here, particularly some colleagues from Sweden. In a month, we have the Global Forum on Migration and Development in Stockholm. It's a forum that is titled Unlocking the Potential of Migration for Inclusive Development. And I'm pretty sure, and we discussed, that there has been no much dialogue of those organizers that are ministries of the interior, ministries of justice, with the health ministries or even the academic community. So I think there is a huge gap that we have to divide. So greater multi-stakeholder accountability. It's not only webcasting the meetings, that's fine, we can do and we should.
It's a start.
It's a start, but I think it's, and we've been discussing this on issues on development cooperation at large, we need much more accountability to the people, not only to the government.
Okay, Daniel, absolutely fine, because of course the World Health Assembly resolutions are not binding, but European law is. You can take enforcement action against member states, and you frequently do. Not you personally, Isabel, of course, but the Commission not infrequently takes enforcement action.
Yeah, but I don't see that that any member state have breached the law, the European Union law, in this area of migrants and health. It's not true, because there is no law that said, not European Union law that say that migrants have to have the same access to healthcare that the nationals of the member state of the European Union. So we cannot open infringement procedures because there is no EU law that has been breached, and we don't have any competence to act against the member state if they have breached human rights, United Nations declaration or whatever.
But you do have a Charter of Fundamental Rights.
Yeah, and what says the Charter?
Well, indeed, it's the member state. But I'm puzzled at this a little bit because I come from a country, United Kingdom, that is only partially attached to the European Union and is very keen on the principle of subsidiarity, and it argues that the European Union should only do those things that are truly transnational, linking member states. And I would have thought migration, by definition, is transnational. I can understand that you might have an objection to some regulation that affects a small shop in the Cotswolds or somewhere like that, but migration by definition involves crossing a border. So why have they, what's happening here?
Has nothing to do with migration, has to do with health. And when we discussed the Lisbon Treaty, and we tried that what now is the Article 168, so the health article was enlarged and was an opposition, not only by the member state, but also by the parliament. So it was not the Commission that tried to do something, but the member state refused, and not just forgot, strongly refused. And there were some articles that were blocked, top secret. Nobody can access to them while the ambassadors, the Coreper, were having the discussion on that. And one of them was the health article. At that moment, I was in the opposite side. I mean, I was on the council, I was as health attaché. I tried to discuss with my ambassador that didn't want to show me the article because it was secret.
So there we are, so I think there's clearly a message there for those of you who vote to elect governments in your member states, who are obviously doing this, obviously not in your name, for those who are here.
And not only governments in your member state, in less than 2 months, in 1 month and a half, we have European Union elections. That usually the level of vote, the percentage of participation is around 40%, because everybody thinks that this has nothing to do with me, European Parliament, nothing, and you forget that many of, well, not many, all the laws are voted in the European Parliament. So at the end we have representatives, MEP, that we say that don't represent us, but don't represent us because we don't care. We didn't care to go to vote, I don't know, between 22 and 25 of May. So they are going to decide in your name.
Well, I've got a couple of questions on Twitter, and then I'll bring people in from the floor. And Anna Isaacs was asking, should academics play a greater role as political advocates? And Barbara, you've already alluded to them as contributing to research, and I've got another question I'll come back to on that in a minute. But as political advocates, should they? Or is, as the epidemiologist Ken Rothman right, is he right that the epidemiologists should leave their values at the door of the laboratory, as he described it? So what do we think? Academics, should they be political advocates?
Absolutely. And as I said, it's about strategic partnerships. Like I really believe there's a role for good evidence, for good academics, public health specialists to sit around the table with ministries of health, ministries of development, who are deciding exactly on the types of things you're talking about, the post-2015 goals and WHA resolutions, ask for accountability on the implementation. And this is not happening. I don't believe at the national level these dialogues are happening. So you have the evidence at your feet, presented to the policymakers and have a discussion.
Well, I kind of follow up on that, because if I look in other areas, we've got Human Rights Watch, and we've got sort of watch organisations in other areas where academics play a prominent role. We have an organisation in the UK called Migration Watch, and it is watching for migrants to keep them out. So they've captured the title, which is a problem for us. Why, Alex, I mean, why do you think that we have yet to get an organisation of civil society and academia that can write shadow reports to hold the member states to account the way they do in other areas? I don't think we have this in migration.
No, I don't think you do. But I should say that there are not many areas where you really have this merging of academics with the civil society organizations. I work very closely with a civil society organization, Help Aid International. In fact, it is based in London, and I act as their global ambassador. Not now that I have retired from WHO, or not as a WHO staff member, but well before, when I was working at the London School. Because I believe that if you are an academic and you hide yourself in an ivory tower, you should be fired. Because it is our obligation to be there in the forefront, facing, especially when you are faced with human rights issues that are very important to have evidence-based, which is what academics are supposed to bring to the table.
Well, I cannot chair and tweet, so I hope somebody will take that comment. If you're an academic stuck in an ivory tower, you should be fired, and tell the world, because I think we can endorse that. But do you think it would help either of the two international agencies here if you had shadow reports? Because in other areas you do, the Convention on the Rights of the Child and elsewhere, organisations hold governments to account, but we don't have them in this area. Daniel?
Most definitely. I think there is a huge role for the academic community, for the combination of academic community with civil society, with, I would say, grassroots movements of citizens to hold politicians and representatives accountable and international organizations accountable. I think it's a system of checks and balance of the global governance that we need, and we should promote it very thoroughly, not only from the institutions, but as interested professionals in the field. So I'm for it. Basically.
Good. Okay, Isabel. Would the European Commission would shadow reports help, or would they just be there wouldn't be maybe an official mechanism for reading them? Would you use them?
we use the shadow reports, whatever organization is doing these kind of things and sending to us. One of the problems with the academic reports, or maybe should not be academic, but let's say civil society in general, because one of the problems that we have sometimes with the academic reports is that they are academic. So in the way that takes time. So 2-3 years later. 2-3 years later, I mean, we have already passed to a new legislation or a new thing. We had something that you can produce, or anyone can produce, in 2 weeks, 1 month. So that arrives when the topic is hot. But it's the same for some of our institutions. There is one wonderful institution, the Fundamental Rights Agency, but that we are waiting for the results of a study on immigrants that was supposed to be delivered at the end of the year. The person that was dealing with that was in maternity leave, so no report. So we will wait for 7 more months. In 7 more months, things have moved.
Okay.
We are discussing a different thing.
Well, Simone Gossen, if I've pronounced it right, was asking if we can think of any examples of successes, and in particular successes where academic research might have had some impact. Is academic research completely useless, or has it actually contributed in a tangible way that we can celebrate? Does anybody have an example? Barbara.
I just came out of a workshop where we talked about the success, and maybe the person from the UK can talk about this, but it took a few years, but the research, especially the public health arguments and the cost, the health economics argument, convinced policymakers in the UK to make antiretroviral treatment available to undocumented migrants. So I think that's a good example. I think what is really key is that Human Rights Watch does some, there's all kinds of maybe accountability on human rights, and maybe there's no specific convention on health, but there are other conventions that migrants can use, like the International Convention on Social, Economic and Cultural Rights and the Convention of the Right of the Child. But I do believe that we should go beyond the human rights argument and look at public health and health economics as well.
So should we in public health as academics be supporting people engaged in strategic litigation, taking cases to international tribunals, the European Court of Human Rights or others, to establish principles? Barbara.
Maybe somebody else.
Or who would that help? I mean, Daniel would.
Absolutely. I believe in a system of checks and balances, and I think this is a role for the academic community to help any advocacy process or litigation process that can create a balance in an unbalanced system where we just have unilateral decision making.
Okay, well, we do have an academic sitting at the back there in the form of Raj Bhopal, who's been trying to get in, and then we have another one down here, and if others want to come in, Alan Karen. So wave your hands at me, and if we could go to the back to Raj Bhopal from the University of Edinburgh.
Thank you very much, Raj Bhopal, University of Edinburgh. I don't think I'm a Superman enough to do all these things that the panel wants academics to do. But let me make a couple of comments. The idea that there's no change in this area is not true. The change has been absolutely massive and unbelievable in the 30 or so years that I've been working in this area. And the change has been so great since the first conference we held in Rotterdam around about 2003. It's hard to believe that this is the same section, the same conference, discussing the same things. The studies are 10 times better, the advocacy is much stronger, the voice of the community is much stronger. Now, one thing I will say, though, is in the last few years, there has been a sense of jeopardy, and that some of our hard-won gains we're worrying about them. But I think there's no better field than this one for reinventing the wheel. And we've already spoken about a resolution that's been largely forgotten, hardly known. In fact, the first time that resolution's been mentioned in this conference is today. It seems unbelievable that such an important resolution has not been mentioned. There's also the consultation, which I was privileged to attend and participate in 2010. It's a marvelous document. Only problem with it is virtually everything that was said in a previous WHO consultation published in 1983. College et al., that particular book and consultation has been completely forgotten, even within WHO. I had to actually bring it to their attention. The amazing thing about these two consultations is they've got the same metaphor on the cover. In the 1983 resolution, they've got the migrants in the shadows, and in the 2010 consultation, the picture of the consultation front cover was shown by Daniel. That's got the migrants in the shadows. So, but no one knows that that consultation took place. And if you look at the recommendations from 1983 consultation, you'll find that actually the recommendations are all the same. The first thing that's emphasized is monitoring. I think we have made a lot of gains, in Europe at least. I'm not saying they've been made all over the world. I think in Europe we've made a lot of gains, but we're in danger of losing the ground here. I think we've lost a lot of ground in England. You know England very well, Martin.
Sadly.
We're beginning to lose a little bit of ground in Scotland, although I think we'll probably be able to regain it there. And across a number of countries, Netherlands makes marvelous progress, and then they take about 5 steps forward, then they take a couple back. That's the way many countries are doing it at the moment. Now, you asked a very important question. Why is this? Well, you know better than anyone else the rise of the far right. And the rise of the far right is the reason, it probably even as important and equally important, or equally important as the recession. I think these two things have made governments incredibly wary, and the media have not helped. They've fueled everything. I think that's making the politicians very wary, because we have the right policies, we have the laws, we have the Treaty of Maastricht, which is legally binding, and it says there will be no discrimination. And we have actually got the laws that can force governments to produce equitable services, because if they're not equitable, they're discriminatory, and that's against European law.
Okay, so Raj, let me hold that point, because I want to come back to it in the discussion, but I want to take a few questions here. We'll go up and down each side. I'll go to Alan Krasnick next, and then, gentlemen, if you could bring the microphone to the gentleman down there.
Alan Krasnick, University of Copenhagen. Well, thank you very much to the panel for this input and starting a very, very important debate. Daniel started the panel opening by mentioning that we have a global agenda. And I would like to question this. Yes, we have resolutions. Yes, we have global consultations. But is the global agenda really existing? Is it a global agenda like the global warming? We are talking about global warming, but temperatures are rising, and we are not doing much about it on a global level. The same thing could be said about migrant health. In reality, I think the countries, even the countries in Europe, have very different agendas. There is a diversity across European countries with very different migrant health issues at stake. Italy, Greece on the one hand, the Nordic countries on the other hand. We talk about migrant health as one concept, but are we really meaning the same thing? I think the lack of solidarity in the European Union regarding migration and health is really a very strong example of the lack of unity and the lack of joint understanding. And then I would like then to just to relate to Alex's point. Aging is an issue, and I agree. Healthy aging is becoming important agenda also in the European Union, and I think we have to tie up with these kind of agendas in order to make migrant health a global issue. Otherwise, we'll never succeed.
Okay, a couple of link points there. Gentlemen over here, and then I'm going to bring after that Karen, and then we'll come back to the panel. Please, if you could just say who you are.
Yes, thank you, Mr. Chairman. My name is Alex Lambert. I'm from Geneva. I'm an academic. I'm a professor of international relations. And of course, yes, I sometimes very often feel I'm very useful. No, useless, of course. But I think there is a possibility to be useful, very much so. I consult and advise an international organization for more than 10 years, and half of my recommendations would be adopted over this period by this organization on a particular document that they adopted 20 years ago. And I think the most important thing is that we have to quit our faculty and classrooms and meet the policy community wherever we can. We have to emerge with the policy community and ask and figure out how we can be useful, and then you can be having an impact. This is actually not what I wanted to say. I had a question.
Okay.
Because
Briefly.
this is this catchword, multi-stakeholder, whatever, multi-stakeholder. And we talk about academia, civil society, we talk about government. But there are different ways to define multi-stakeholder approaches. And I would like to suggest you the third pillar, which is the private sector. You should add the private sector in your radar screen. What is the role of the private sector in terms of responsibility and accountability? This is my question.
Okay, thank you. And Karen Strongs, please. Have you got a microphone to there?
Thank you, Karin Strongs, University of Amsterdam. I feel excluded because I do not Twitter. So thank you for the microphone.
But you will.
Related to the point that Alan raised, I would like to ask the panel, is the problem clear enough for policymakers? Migrant health, we are discussing this for 2 days and everybody here in the room seems to have a different perception of what that means and what the problem is. If you ask policymakers to develop laws or take decisions, do they know where they have to take decisions about? And is it not partly our fault that they do not know what to decide on because we are not clear in what we actually mean and very good in raising problems and bringing up problems, but not very good in bringing up solutions and telling what to do about?
So there's a number of interlinked issues coming out here. And Raj reminded us about the rise of the far right in particular. And the political context. We have European elections coming up, and some of us are looking to them with a degree of dread, given what we see in the opinion polls at the minute. And that takes us to this issue of framing of the problem. Is the problem a problem for the migrants, or are the migrants seen as the problem? Is that an issue that we haven't, that we struggle with, because in fact, there is a political divide on that, where where it is highly politicized, one of the top issues on the political agenda in a number of countries. I'll come back to the other points in a minute, but let me just...
Martin, let me interrupt you.
Please, I want you to.
And ask this audience, how many of you consider yourself migrants? Could you raise your arms? How many of you have parents that were migrants? So you see, it is sizable. It is here. It's here to stay. You look at this guy who is helping here. You are from Colombia, aren't you, Jairo? The other guy that was right at the door was also. There are 4 Latin Americans here. Latin Americans that if it were not for your work, we wouldn't be here and facilitated into our work. And we have to bring this voice more actively. It's not something diffuse, but really we are talking about our rights as well. And as academic, we have to be aware. It's not a distinct group that is out there in the community. We're talking about a community that is right here represented. But please consider you too, Jairo. You are young, but you are going to age. You are not forever going to be productive and active. I hope you will age, because the alternative is bad.
Well, let me go back to Karen's point, because if we look at the theory on policy changing of kingdoms model, you need a problem, a solution, and a window of opportunity. And we have a challenge in terms of defining the problem. But Raj was making the point that the progress that has been made, and which is demonstrable at this conference, is enormous. The material that is here is incredible. There are solutions. I think there are solutions. I'm hearing solutions. So have we brought those two bits together? And what would be the window of opportunity that we need to make it happen? Daniel.
Yeah, first of all, in terms of clarity on the definition of the problem, if I just look at the way in which high-level officials in the General Assembly in October were discussing the matters, including migrants' health. Not being from the health sector, I would say they have it very clear, but they don't necessarily want to talk clearly about it. So let's frame that.
Let me just come on that, because I'm wondering as I listen to this discussion if we have a situation whereby governments go to international assemblies and say one thing in the hope that nobody at home will hear what they're saying. Because if they did hear what they were saying, then perhaps their electorate who would be less supportive.
There is definitely a double
issue?
discourse. I think there is an issue there. Because, as you rightly said, if you just look at the political environment, the upcoming European elections, but many other elections nationally, well, migrants are seen as a problem. And then politicians try to respond to their constituencies following that logic of the perception. This is an area where a lot of social pedagogy is necessary and is not taking place. Let me just say one more thing. I fully agree with Raj on the issue that some of the problems have been clearly identified in the 83 meeting, in the 2010 consultation that we did. But let me also tell you, the official development agencies, or official development aid agencies of the countries you are coming from, do not identify as a priority migrants' health. You will not get funding, and we have tried, IOM and WHO together, to get funding for this, or funding through the decision-making in the budgetary process of our organizations, and we have to fight an upstream battle.
Let me challenge you on that a little bit. I put it to you that perhaps the development agencies are interested in migration, in that they want to put in place policies to remove the push factor so that they will reduce the number of migrants. Would you accept that?
Yeah, I accept that, but they are not looking at the other side of the equation.
Yeah, sure.
And that's where you don't. And just last point.
Yes, sir.
On Alan's point, because I think it's very important. Is there a global agenda or not on this? I think that by nationalizing or regionalizing the agenda, we have contributed to the dilution of the global agenda on migrants' health. Of course, you have to nuance and contextualize the problems depending on the places, but I do think that there are some common threads that may have slight differences here and there, where we have to work much more on the commonalities than on the differences.
Okay, can I come to the point on the private sector? You make a very important point. They are clearly a very key actor. But when I look at the role of the private sector in delivery of healthcare, I see organizations that are interested in treating people with simple, straightforward conditions that are predictable. Markets hate uncertainty. So we get disease management packages for people with diabetes. But elderly people, the people that Alex was talking about, who are more and more the migrants, are people who have multiple complex combinations. Do you think that well, I look to all of you, will the private sector be interested in those groups of people, or will it take the easy groups and leave the state to pick up the complicated bits, but potentially by taking a disproportionate share of the money? I just wonder.
Well, if you ask me, Martin, the private sector will always look at where's the profit to be made. And if we are talking about people that are particularly vulnerable with multiple pathologies, that at the end of life will be, and I was talking about the culture of care, that will need care, these are not the people that the insurers will be interested. That is why we need a strong public sector, and I agree that the agenda of the far right and neoliberal is completely against the interests of vulnerable older people with multiple pathologies that will cost a lot of money. So if together the academic community are not going to join forces with the NGOs, the civil society, they will be deeply unprotected, and that includes many of the parents of yourselves here.
Martin, can I just
Please, Barbara, please.
Just maybe one more small point about the private sector is a good point. That when I actually think about the private sector in the context of migration, was I mentioned it on labor, for instance. You know, obviously employers are important private sector actors that can do a lot for migrants' health. Providing basic social protection and health, such as health insurance, can be an enormous factor. The difference here is that usually when you talk about workers, they're young, they're healthy, they come to work. So access to some basic social protection and health is extremely important to keep them healthy. And you do see much more interaction of the private sector in the migration debate. That it is encouraged and strengthened. In fact, at the GFMD that Daniel's meeting, there is a specific private sector roundtable that includes people from the health sector, especially as health professionals are migrating in minerals, for instance.
Daniel, can I bring you in on that? Because if we look at the large employers, particularly in the mining industry in Africa, we know that mines are incubators for multi-drug resistant TB. We've shown it, others have shown it too. And so one could argue that the mines in particular have a responsibility, not just for their workers, but for the communities from which those workers come from. So we see a clear relationship between employment in the mines and MDR, TB and HIV in Swaziland, Lesotho, Mozambique and so on. Is that, do we see that they're really engaging in not just their workers, but in the communities from which the workers come?
Yeah, I think the point you're raising is very important. We need to deconstruct more the issue of the private sector in this area, because there are very different logics. First of all, let's not delude ourselves. We understand, we know that the accountability of the private sector and the logic of the private sector is profit. Now, having said that, there is room for corporate social responsibility, some responsibilities with workers that can be taken advantage of. I have seen development of interesting social protection schemes by employers, by private sector in the US border with respect to Mexican workers, illegal migrants, that are way beyond the public policies or way beyond the policies that some NGOs could organize. But that doesn't mean that we are going to be able to reconcile the logic of the private sector equally for all aspects in the solution on migrants' health.
And isn't there a potential conflict here? Because if we look at the fruit industry in California, for example, agriculture in the southwestern United States, if those migrant workers were entitled to citizenship and the rights that go with that, it would cost a lot more for us to get our Californian fruit, wouldn't it?
Yes.
So is there not a mismatch of incentives? Okay, Carlos, you wanted to come in, and do you want to come back on these points? Carlos, please. And are there other people who would like to ask questions? Because I'm looking for tweets here, and I'm not seeing very many of them. So if you really want to capture my attention, oh, I've got another one from Simone, thank you. If you really want to capture my attention, this is the way to do it. Carlos.
Thanks, Martin. 3 small points. The first is that, in my opinion, migration is a global phenomenon, has been always like this, and should be, global rules for that. But the problem is that there is not borders and frontiers for money, for businesses, and so on, but there is, of course, borders for people to move on, especially if we are talking about movements from the south to the north. Not is the same, it is south from south and so on. The second, I think we have to contribute to create a new narrative about migration and ethnic minorities business, because the current dominant discourse is completely against the interest that we are expressing here in this conference. Let's take the case of Spain. Over the last couple of months, all the things in the media related, and the politicians related to migration, is related to delinquents, danger, invasion, and so on and so forth. This is very important. These are the words, and the narrative of the discourse are making minds and are influencing very much. The third, I do consider it is extremely important to have a great and agreement, European agreement on immigration policies, including European institutions, civil society, churches, a very intersectoral, multisectoral approach, in order to minimize the for right-wing or exclusive discourses that are going on, as you know, in many European countries. So we have to push as scientific community, as practitioners, public health people, for a big European, it's a European problem. It's not the problem of Spain, of Italy, or Greece in the borders or other. It's a real European problem, not problem, sorry, challenge, that we have important challenge that we have to address at the European level. And on that I think that we can do much. And we have to force, try to push for this agreement in the coming months in order to, again, minimize the xenophobic and the racist discourse that is going up, unfortunately.
And there will be a firm statement coming out from the Granada Declaration. Can we bring in, just, I think Lelia Gretelsdottir was first, and then Lillian up there? Yeah.
Thank you very much, and thank you for all of you for your excellent presentations. I've been trying to stop myself from saying what I'm about to say, but I can't stop myself really. And I'm saying this as an Icelander and as a person who was extremely involved in the aftermath of the financial collapse of Iceland and all the things that went on there in the wake of the collapse. What I want to say is this: yes, it's absolutely true that government commit to all kinds of things internationally, and then we have to find ways of how to hold them accountable to what they say and what they commit to. This is a whole area that is very interesting to discuss and invest. Another area I do want to address, however, is how domestically governments in this crisis, and here I speak again as an Icelander, have been pushed by organizations such as the IMF, the European Union, etc., have been pushed towards much greater austerity measures than the populace actually gave the government's mandates to further. One example, for example, in Iceland, across political parties among the popular vote, for decades, and this is still the case, a vast majority of Icelanders want a public health care system based on equity, where you pay through your taxes, where people don't pay when they come, etc. But there's been great push factors of changing the system because of austerity measures, because of, you know. So I just want to say, domestically, people also have to stay true to their populace and also resist pressures from this all-encompassing philosophy of austerity. Thank you.
Okay, thanks. I'm going to take two more. Lillian Gomez from Portugal at the back, and then one. So Lillian, do you want to go ahead, and then we'll get a microphone to you here.
Hello,
Please.
thank you for all the talks today, and these 2 days have been really, really interesting and the best way to learn. It's interesting that while we were having this discussion, I received a request to sign a petition on a law that is about to be approved in the UK, where doctors, GPs and doctors in accident and emergency are asked to check the immigration status of the patients and then to charge them in case they are illegal immigrants. So I think that's how can we, after all these discussions that we have been here, that we have had here, how can we still tackle with this kind of countries that are developed and still take these kind of measures?
Okay, final question from there, and then we'll come back to the panel. But before you do, one of the questions from Simone Gosen has been, what are the priorities? And I'd like you to each, while we're thinking, think of a priority for action that we can take forward in all of this, please.
Yeah, only a very quick testimony. Yesterday, our clinic...
Just remind me who you are.
Natalie from Doctors of the Word. Sorry. So yesterday afternoon, our clinic in Athens was surrounded by 30 people of Golden Dawn, screaming hate slogans and racist slogans. So the people, the children inside the clinic were really terrified. The only very good thing is that they're so stupid, they're going to the only place in Greece where we receive 90% of Greeks. But they, okay. But the real thing, okay, so then afterwards they left. but the children were terrorized. But today, one of the ministers in Greece, not the Ministry of Health for this time, tried and explained that Doctors of the World Greece had bought some hygienic supplies from Golden Dawn. And this is the way, you know, like they try to break the credibility of the few NGOs who absolutely refuse to take care only of Greeks, which are the ones who today are getting the fundings, because the people who don't accept to treat only Greeks don't get the fundings anymore. So I think we have to be very serious about this question about the rise of hate speech, and that we should also link better with the Fundamental Rights Agency and all the people, and try to really be very strong also tomorrow in the declaration.
Okay, well, there are a number of comments there, Lillian. I would just point out that we have written a paper in the current Journal of the Royal Society of Medicine about the law in England, condemning it and making the case that charging migrants is the first step in charging everybody. And Lelia, as you say, there is a tremendous push by, unfortunately, the current Australian government in OECD to push for co-payments. And we see the right-wing think tanks in England pushing for co-payments very, very powerfully at the minute. You can see a clearly concerted campaign with the King's Fund joining in, having forgotten about their founding principles. So that just put that on the table. But I'd like to pick up just briefly on this issue of borders, because there is a problem here, isn't there? The European Union has freedom of movement, the four principles of goods, services, capital and people. But in the rest of the world, we have free movement of goods and services and capital, but we've forgotten about the people, haven't we? Is there a problem here? I leave that because I want to now come back to this point about the priorities. What are the priorities? Each of you come up with one priority that we take away. Barbara.
Well, it was actually quite a difficult question.
Just one.
But I think if we could do one thing right, would be to have a very short, nice presented with messages around cost effectiveness of providing healthcare to migrants, including undocumented migrants. We need to present the health economists and the public health arguments. That's the key thing that public policymakers will look at.
So we need to get the evidence and we need to present it.
I think a lot of the evidence out there, I think it's a question perhaps of combining it into one easy, readable, presented document.
We need the Lutheran approach where we write it on a piece of paper and nail it to them. That's the way to do it. Okay, Alex.
If you ask me the priority, I would think of three letters. VIP. It's V for vulnerability, I for inclusion, and the P for protection. And if I bring these three together, the VIP, I would think of all the migrants because they fare very poorly in all that. And if any of you would have an interest on this, and I hope you will, there will be the second international conference on migration and aging in Australia, a country of migrants, where 40% of migrants are old. So it is a very important issue for them, and they are starting to really mobilize. So this conference is on the 16th to the 18th of June in Adelaide, and if you want any information, I'm involved with the organization of this conference, so please do ask me.
Okay, Isabel, obviously one priority is that you all vote for somebody in the European elections if you have a vote, so that is a clear message, but beyond that?
Beyond that, well, I don't know. First, one tool that is here. I mean, we have been gathering interesting idea, but we are already preaching to the converted. So, is there anyone here that thinks that the migrants are a burden for the societies? Okay, so it's clear that we need an audience that is different. So this is the tool. And related to the tool, maybe a priority that is that we stop to talk about the healthcare or the health of the migrants in the European Union, and we begin to talk about the health or the healthcare to the people in the European Union, and people means everybody. And then I will have a point for Natalie, but later.
Okay, thank you. Daniel, your one priority.
Thank you, Martin. I think it's going to be extremely important to work in the coming years doing three things. One, documenting better the opportunity cost in terms of public health and in economic terms of not delivering care to migrants. Second, there has to be a much greater push towards a social movement that builds portability in health across countries. And we have not put sufficient emphasis on that, and this is not going to come naturally from governments. And third, I think it's very important, we discussed it today, to hold governments and hold international organizations accountable through shadow mechanisms of accountability.
So there we have the Holy Trinity, 3 priorities in one. Thank you very much indeed. I must apologise to Annalie Rosted because your tweet just came in at the end, and this was, can we have more opportunities for WHO, the IOM, the UN High Commission and refugees to work together? But hopefully that's something that they can discuss this evening at the Alhambra and come up with a new strategy. We've run out of time. Can I just say thank you to all of the participants in the panel, because especially those from the international agencies, it's not easy, and although we know each other well, it's not easy to be in a panel that I chair, because they never know what they're going to get asked. And
it's a pleasure.
It's always a pleasure being with my very good friends here, but thank you to all the panel, and thank you for your contributions, and keep tweeting. Thank you very much.
Thank you. We are meeting in less than 1 hour on the ticket office entrance of the Alhambra at 7:30. Thank you. In the Generalife entrance. Thank you.
I'll just say. And if Annalie Rosted would make herself known to Barbara, you can follow that up later.
Buen viaje. Nos vemos.